Thank you very much for that introduction, and I'm delighted to be here. I've heard a lot about Kyoto from my director, Professor Peter Peart, who always loves to come here. So when I was invited, he said, I really must come. So it's a pleasure to be here in my first visit to Kyoto. So since this is a meeting of rising young researchers, I thought before I directly address the topic of this talk, I thought I'd just give you a little bit about my background and also use some of my own work in the examples that I'll give you in this talk. That also means that most of the examples I'm going to use in this talk are from low and middle income countries, because that's where my career has focused. So my background, I studied history and economics at the University of Oxford and focused especially in development economics. And that was because I come from a family that has been engaged overseas for many generations, including the Indian civil service many years ago. And so I was interested in how other countries in the world developed. Following my university degree, I joined a scheme that provides economists to countries that at that time did not have enough of their own economists. And I was offered the position of economist in the Ministry of Health in Malawi. And that really started my career in health, really quite by chance. I hadn't thought about going into a career in health economics before that. I then spent a few years working on the National Health Service in the UK, on the planning system of the National Health Service. And then I joined the school in 1979 and have been there ever since. And during that time, I've essentially worked to build up a research program in health economics, focusing initially on the economics of malaria, and I'm going to talk a bit more about that, and then the economics of health systems in low and middle income countries. And I suppose I've been fortunate. My career maps the development of the modern era of health economics. So health economics really began to develop as a sub-discipline of economics in the late 1960s in the US and the UK. In low and middle income countries, it began to develop from the 1970s, particularly with the posting of people like myself within planning units of ministries of health. I wasn't the only economist to be in a planning unit in a Ministry of Health in the early 1970s. And so health economics has been developing over the time that I've been working as a health economist. So I find it quite interesting to look back at how health economics has developed and to reflect on where it needs to go in future. So just to spend a moment on the origin of health economics, as I've just said, my first degree was in history and economics, and so I always like to reflect on the historical origins of what we do. So health economists like to claim their origin in the work of Sir William Petty FRS, who lived between 1623 and 1687 in the 17th century. I might add that epidemiologists also like to claim him as a founding father. He basically applied quantitative thinking to health problems. I find it fascinating that the themes that he contributed to are ones that we still discuss today. So, for example, he quantified the value of human life in terms of an individual's contribution to production. We would now label that the human capital approach. In his pamphlet of Lessening the Plagues of London, at that time London was, had outbreaks of plague that killed a lot of people, he showed that removing people from London during the plague was an excellent financial investment, a return of £84 for every pound spent, a very early cost-benefit analysis. And even more surprisingly, perhaps, he addressed the question of the relative roles of public and private sectors. He argued that all should have equal opportunity for medical care. That's an early expression of universal coverage. that there should be state medical service of salaried doctors, that it's not in the interest of the state to have physicians and patients as now leave to their own shifts. So interesting, so many years ago, so many centuries ago, to have those issues addressed, and I'm going to pick up those issues as I continue this talk. So there was some continuing work that might be described as health economics in the 19th and 20th century, early 20th century, particularly cost-benefit analysis and an analysis of the economics of health insurance. But the real development of economics, of health economics, came in the 1970s onwards. In relation to low and middle income countries, that development of work initially focused on economic evaluation, cost-benefit, and cost-effectiveness analysis. And I'm going to talk about some examples of that in relation to guiding malaria control policy. And then a bit later, a lot more work developed on the financing and organization of health systems, what we now call health systems research. And I'm going to talk about some examples of that relating to financing of the health system and public-private roles, particularly access to medicines and contracting out services. In giving the examples, what I want to address is how health economics has shaped itself to seek to inform policy, whether for good or for worse, and I'll address that later towards the end. So my first involvement in malaria was in Nepal in the 1980s. You may know that WHO declared a campaign for malaria eradication in the 1950s, and that was initially very successful, but after a while it demonstrated that eradication was simply not feasible. And by the 1970s and the 1980s, there was a lot of fatigue about the cost of maintaining the control measures. And I was asked to look at this in Nepal. The external funders of the malaria control program wanted to know whether they should continue to invest in malaria control. Was it worth doing? So the question they were asking was a cost-benefit analysis question. Should we be investing our money in malaria control in Nepal rather than other aspects of development in Nepal or indeed in other countries? So I've called this the dark ages of malaria control because it was the time when there were a lot of questions as to whether malaria control was even worth trying to achieve. So Nepal was an interesting country. At this time, there was a lot of justification of malaria control as a way of opening up new land. The narrative was that because of the amount of malaria in particular countries in Asia, land was unproductive, unused, and that therefore if you put malaria control measures in place, it would enable that land to be productive. And that argument was very commonly made for Nepal. So what I did was a cost-benefit analysis, looking at the costs of the malaria control efforts over time, and then at the benefits. And in this case, the benefits were translated as the benefits of new land becoming available. So what I did was look at extensive historical documents, spending a lot of time in the university library in Kathmandu, looking at the population censuses, looking at the movement of people over time, looking at agricultural returns, looking at changes in crop production over the years. And it became clear that this area shown in the upper photograph, known as the Inner Terai, which was surrounded by hills, that this area had had relatively few people, and that it did indeed seem as if the malaria control efforts had enabled people to move into that area and to survive. There were historical accounts of immigration into the area where many people and children had died from malaria. So what I estimated was the cost of malaria control was around 25 rupees per hectare per year. But if you actually calculated the returns to labor and to land of new settlement in terms of the production that was then made possible, those benefits were several thousand rupees per hectare per year. So it was very clear that the investment in malaria control was worth it, and indeed that continued investment was worthwhile. So that was an example of cost-benefit analysis, and there were similar cost-benefit analyses of malaria control in other countries like India and Philippines at the time, all demonstrating very positive benefit-cost ratios. The next question I was asked to look at was the question of malaria control in Africa. And Africa was largely left out of the malaria eradication program. It was thought to have such high levels of malaria that it was simply not worth trying to, certainly not attempt eradication or even really control. But in the 1990s, there was greater awareness of the health consequences of that, of the very high burden of malaria in terms of childhood deaths. And I was commissioned by WHO to explore the cost effectiveness of different interventions. They wanted to know, were there interventions available that appeared to be cost effective and could control malaria? And so I used a technique of cost effectiveness analysis, a modeling technique called probabilistic sensitivity analysis, and demonstrated that both treatment and prevention were highly cost effective in Africa. And this evidence was used to help justify the creation of rollback malaria in 1999, and that still exists now. And indeed, there's been a rapid and very significant scale-up of malaria control in Africa, with a significant reduction in the numbers of cases and deaths. So this is the sort of output that those analyses produced. These are ranges of cost effectiveness. This probabilistic sensitivity analysis technique, for those of you who don't know, it involves drawing values of the different variables from the literature, calculating minimum and maximum ranges for each of the variables, and then iterating the cost effectiveness calculations many, many times with random selection of the values of the variables, so that you end up with this distribution of cost effectiveness ratios and the range that the ratios are likely to fall in. And so what you have here on the left-hand axis is the cost per disability adjusted life year gained, so translating lives saved into DALYs. Along the bottom you have the interventions. We looked at some of them: ITNs, insecticide-treated nets, whether treated only or including the cost of the nets, spraying 1 or 2 rounds, that's with insecticide, and then prophylaxis, including or not including the cost of a volunteer network. There's always a question with cost-effectiveness ratios as to how do you evaluate them? How do you say, is this a good buy or not? And it's customary to use $100 per disability adjusted life year gained as some sort of a benchmark for indicating a highly cost-effective intervention. I think my colleague John Cairns, when he speaks tomorrow, will talk more about these issues of thresholds. But if you accept that $100 per DALY is a rough indication of a highly cost-effective intervention, then you can see that all of these interventions were highly cost-effective. We also disaggregated this analysis by whether there was high levels of transmission or lower levels of transmission, because it makes a difference to the analysis. And then my last example of malaria control, another very policy-oriented example, is the example of what's known as the Copenhagen Consensus. This was introduced by a Danish group in the 1980s, and essentially argued that cost-benefit analysis should be used to evaluate the opportunities for development funding. So asking the question, should the world decide to invest a fixed amount of funding, I think it was $50 million, in emergency relief or trade or nutrition or health, whatever. Where you want to evaluate choices across very different sectors, cost-benefit analysis has to be the tool you use, because you estimate both the costs and the benefits in monetary terms. And so the tool was cost-benefit analysis. I was asked to address the subject of communicable diseases. And the proposals and the estimates were then evaluated by 8 top economists. The photo shows them deliberating. 1 woman out of the 8. So these, in 2004, these were the rankings produced by those cost-benefit analysis of each of these areas. This has continued. This is just the 2004. There have been other rankings since. The ones that I looked at, control of HIV/AIDS, control of malaria, and then scaled up basic health services, which was a third option I took, all ranked very high. And I think this demonstrates 2 important points. The first is that when one undertakes these sorts of analyses, they provide powerful arguments for investment in health. However, one does these calculations, and these calculations are not straightforward, they have many uncertainties. Nonetheless, it does appear that in terms of this sort of cost-benefit analysis, health interventions come out as some of the most attractive from an economics point of view. But just to comment on the last one there, scaled up basic health services, I included that because, as we all know, diseases aren't addressed one by one within a health system. They're addressed as part of an overall structure of services. And that basic health services are primary health care, whatever you want to call it, are in the end how all of these disease-specific interventions are delivered. But the technique of economic evaluation is not at all well suited to analyzing groups of interventions as opposed to individual interventions. And so in trying to calculate the costs and benefits of basic health services, the cost side is easy enough to estimate the costs of an infrastructure of services. The benefits are much more challenging because one has a mix of benefits from different diseases, different mixes of mortality and morbidity benefits, disability reductions. And it's not easy to convert those into some large estimate of disability-adjusted life years. There has been some research that has tried to estimate the health effects of broad primary health care, but it's fairly inconclusive. And so my personal view in this analysis is that basic health services were disadvantaged because it's quite easy to estimate the costs, but very difficult to adequately estimate the benefits. Oh, this is I sent another version of these slides. I cut those 2 out. So that's all I want to say about malaria control. So just to give you some examples of some of the work I've done in the past, where techniques of economic evaluation, cost effectiveness, cost benefit analysis, shared useful insights that were relevant for government policy and found to be useful by policymakers. Moving on now to economic analysis within health systems research, and talking first about financing. So I said that in low and middle income countries, the initial development of health economics primarily concerned the application of economic evaluation, cost effectiveness, cost benefit analysis. From the 1980s, there was a growing debate on health financing, the relative merits of user fees, community health insurance, social health insurance, general tax funding. And in the literature, one can see an increasing volume of health economic studies on financing. And I want to give you one example I was involved in myself, and that is on community health insurance. So community health insurance is insurance that is organized at the community level, run on a not-for-profit basis, and involving risk pooling across households. In the 1980s, it was a very popular topic. It was thought to be the best way of providing financial protection to rural communities. But in general, the experience was that the schemes were very small, covering a few thousand of people. But there were a few large ones, notably one that was run by the Self-Employed Women's Association in India, known as SEWA. And SEWA was a trade union of women in the informal sector, garment pickers, street sweepers, and so on. It was a relative success at its peak. It had 100,000 members, paying roughly at 60 rupees a person per year. And they paid for hospital cover. This wasn't outpatient care. If they needed to get hospital care, they went to a hospital, got admitted, paid themselves, and then claimed back for the cost of the care. But I was involved with colleagues and working with SEWA to look at that scheme, and we found that it was inequitable, that they did very well at recruiting the poorest women to the scheme, but the poorer women claimed fewer healthcare benefits than the less poor. And let me give you an example of that. So this shows the distribution of members and of claimants, those who got hospital care, paid for it, and then claimed back the cost. And this classifies them by deciles of socioeconomic status. So the dark blue shows the population of members on the left and claimants on the right, divided into tenths in terms of their level of socioeconomic status. And the bright green bars shows the distribution of members by socioeconomic status. So you can see on the left-hand side that the membership is indeed slightly skewed to the poorer socioeconomic groups. That's to the left-hand side. But on the right-hand side, that's a distribution of the claimants, the women who claimed for the cost of their care. And that's very clearly skewed towards the less poor. So the scheme was doing well in recruiting poor members into the scheme, but it was doing much less well in ensuring that the poorer members had equal opportunity to benefit from the scheme. So what we did was design a cluster randomized controlled trial. Economists in recent years have got very fascinated by the tools of epidemiologists and have adopted them for their own purposes. So this was a cluster randomized trial to test interventions to raise insurance claims by the poorest. We think it was probably the first randomized controlled trial to have an endpoint that was explicitly an equity-oriented endpoint to increase insurance claims relatively more in the poorest. So there were two interventions. One was supportive supervision, providing greater supervision to the insurance worker, who was herself a usually illiterate, low-income member of SEWA. And then the second intervention was to negotiate with hospitals so that there were named hospitals women went to, and then their care was paid for there, rather than women have to pay in advance and claiming back. So the outcome of this trial, this was the main analysis, looking at the socioeconomic status of claimants relative to members. We didn't find any intervention effect. There was, however, a significant increase in the claims submission, but everyone within the trial increased their claims, and that wasn't preferentially in favor of the poorer women. And the conclusions we drew from this was that providing financial protection on its own is not enough, especially if you looked at the circumstances of the poorer women. They were living in more remote areas. They were further away from health facilities. In this area in India, they had very important family responsibilities that made it difficult for them to leave their household because they had responsibilities for cooking and cleaning, looking after children, and so on. And so only removing the financial barrier is essentially not enough. And these conclusions have been supported by more recent work, particularly a study in Ghana, similarly a randomized controlled trial, which similarly found that providing financial protection didn't have a lot of effect on increasing utilization rates or in improving health outcomes amongst the families that were given coverage. So I'm not saying that financial protection isn't important. Clearly it is, but it's not enough. And in retrospect, in the 80s, when we were focusing so much on financing, that was a very partial view of the sorts of changes that need to be put in place in health systems, that you can't just focus on the financing side, you have to look also at the provision of services. So then moving on beyond financing, and indeed by the 1990s, the focus of health economics was extending from financing to broader systems questions. For example, how to finance the whole system. A health system isn't financed from just one source of money. Any country has a mix of different sources, whether insurance, general tax, user fees, and so on. Examining also issues of the organization of healthcare delivery, the operation of healthcare markets, and the roles of public and private sectors. And indeed, in the 1990s, there was growing interest in universal health coverage. So to take that last topic first, I know that some of you in the audience are from Thailand. Many of you probably know the story of universal health coverage in Thailand. It was introduced in 2001. And I think one really important aspect of Thailand is that their health system reforms have been informed by a substantial amount of economic and other analysis that has been done over the years, that was done to inform the design of universal health coverage and has been done since then to monitor it, as I'll show in a moment. Thailand is unusual because it used a combination of general tax funding and social health insurance. In general, in Asia, general tax funding has not been a popular source for larger amounts of money going to health. Governments have wanted to put much more emphasis on social health insurance and then extending insurance to the informal population. For example, as Vietnam has done, as China decided to do. So Thailand is unusual in having general tax funding as the major contributor to the funding of universal health coverage. So I was part of this independent assessment of the first 10 years of universal health coverage, and just to show some of the evidence from some of the achievements in Thailand. So universal health coverage has clearly led to increased service use. The upper line there is outpatient visits, the lower line inpatient admissions over the period from 2003 to 2010. More sophisticated analyses more recently has, clearly this is just showing trends over time, there's been more sophisticated analysis trying to introduce some form of controls. For example, there's just been a paper published looking at Thailand relative to other countries, using other countries as a control that haven't introduced universal health coverage, and those analyses largely support these ones I'm showing here. What Thailand has also seen is an improved equity in service use. Economists have tools of financing incidents and benefit incidents to assess to what extent the financing of a health system or the benefits of a health system are pro-poor or pro-rich. Thailand has done several of these incidence analyses, and this is one of them. This shows the analysis for ambulatory care. It disaggregates the use of services by different levels of care, health centre, up to provincial hospital, private hospital, and overall. And this graph shows concentration indices that come out of the benefit instance analysis. If they're pointing downwards, it indicates that the incidence of healthcare benefits is pro-poor. If it points upwards, it's pro-rich. And the different coloured bars are for different years of the surveys. So you see that over time, in general, the incidence of healthcare benefits has become pro-poor, though it's quite interesting to note that it was in fact pro-poor before the start of These are the benefits, that is, before the start of universal health coverage. The private hospital pro-rich is not surprising. Those are people who are opting out of their universal health coverage benefits and choosing to use their own resources to buy private hospital care. But overall, this does show an increasing pro-poor nature of the health system with universal health coverage. And this sort of tool, both looking at the incidence of benefits and looking at the incidence of payment, is quite a powerful tool to monitor the incidence of payment and of benefits within a health system. And then also important, analysis of the change in catastrophic health expenditure. Here, catastrophic health expenditure is household spending on healthcare that exceeds 10% of total household consumption expenditure. So this shows the proportion of households in each socioeconomic status quintile incurring catastrophic health expenditure. And just to point to the lower line, the green one, which is the, sorry, not the green one, the blue one, which is the line for the lowest, the poorest socioeconomic quintile. Back in 1996, roughly 7% of those households incurred catastrophic health expenditure in any year. By 2009, it was down to about 3%. So showing significant benefits in financial protection. And noting also reductions for other quintiles, which I don't want to dismiss. They also benefit from that. But in this sort of analysis, one's particular concern is the poorest. So my last main topic is that of public and private roles, an area that health economics has put quite a lot of attention into. And I want to address briefly two topics: access to medicines and contracting out. So turning to a very different sort of healthcare issue, that of the distribution of drugs. In many low-income countries, most people get their drugs through low-level retail outlets, not proper pharmacies, not public facilities, not formal hospitals, but various forms of shop. So this is from data from a number of countries in Africa, shown across the bottom line, from surveys of sales of anti-malarials, drugs taken for malaria. That's the share that came from public health facilities. That's the share from private not-for-profit health facilities, mainly church facilities. And that's the share from private for-profit outlets, primarily shops. And then a very small proportion from community health workers. There's been a lot of attention focused on retail drug sales for a number of reasons. One is clearly quality, concern about the quality of drugs. But in relation to malaria, it's been a major concern because of the growth of resistance to traditional drugs for malaria, particularly chloroquine. And chloroquine was the mainstay of malaria treatment throughout Asia and Africa for a very long time. But in the 1990s, it was known that chloroquine was failing. Certainly in Africa, deaths were rising because of that. And the decision was made to switch to Artemisinin, but to an Artemisinin combination therapy, a combination of drugs that would help protect Artemisinin itself from the development of resistance. And so this type of pattern of drug prescribing or of drug sales presents enormous problems for changing policy, because the government can change the policy on what drug to prescribe in the public sector, but in the private sector, it's extremely difficult to control. So, because of this challenge of how to change the world onto Artemisinin combination therapy, an Institute of Medicine committee was set up in the US, incidentally chaired by Ken Arrow, whom those of you in the audience who are economists will know of Ken Arrow as having written one of the most seminal of the papers on health economics. He chaired the committee and recommended a global subsidy for Artemisinin combination therapy. And that was explicitly justified on economic grounds. One ground was that bulk purchasing at the global level would drive down the cost of combination therapy. The other argument was that given this widespread purchase of malaria drugs, what you needed to do is get the best drug, to get the price of that best drug so low that it competed out the other drugs in the market. And they were especially concerned to compete out Artemisinin monotherapy, because Artemisinin monotherapy was known to be at great risk of encouraging resistance very quickly, whereas combination therapy protected the artemisinin. So the Affordable Medicines Facility in Malaria was set up by the Global Fund to supply subsidized artemisinin combination therapy through public and private outlets. And that was almost a revolutionary decision. It was one that was extremely controversial, has continued to be opposed. But the rationale was that these drugs are out there anyway, people are buying them anyway. Regulations are notoriously ineffective in the private informal sector. And therefore, the recommendation was to try and use this mechanism of subsidized drugs. And colleagues of mine were involved in research to evaluate this program. And so just to be brief, this shows the market share of antimalarials in private for-profit outlets in these African countries. The only bar to worry about here is the green bar, which shows quality-assured artemisinin combination therapy. This shows base and end-line surveys for these various countries. And it shows that in all of these countries, there was a significant increase in the availability of quality-assured artemisinin combination therapies through this subsidy program. I haven't shown the public sector data here. There was also an increase in public sector availability at the same time. And obviously, there was a lot of concern about the price. The price was fixed. Was that fixed price maintained for the end user? And the answer was that yes, in general, almost always the price the drug was sold at was the one that it should have been sold at. And there were issues of diversion of the subsidized drugs elsewhere in relatively few cases. And then my final example, the example of contracting out. So in the last 15, 20 years, contracting out has been a commonly recommended policy of agencies like the World Bank, starting from a point that if you look at the quality of government, cost and quality of government services, it's often not very good, and arguing that if governments, rather than provided services themselves, that if they contracted services from the private sector to run, that you might get better cost and better quality. So I was always interested in this as a research topic, evidence very, very weak. And we took the opportunity of a scheme in South Africa. This was actually a scheme that was a local scheme. This didn't come about as a result of recommendations of the World Bank or anyone else. The situation had arisen because several provinces had built new district hospitals and for various reasons had not been able to open them. And so they contracted a private company in South Africa to run the hospitals on their behalf. This affected 3 hospitals. These were just local district hospitals that are in this graph named the contractor hospitals. We paired those with 3 local district hospitals that were run by the public sector. We also looked at 3 hospitals in the private sector serving the privately insured population. Very different sorts of hospitals, so I'm not going to talk about those more. And we then looked at the cost of those hospitals and at the quality, looking at various measures of structural and process quality, and at the overall arrangements for the contracting process. So what we found was that the cost per admission in the contractor hospitals was lower than that of the public hospitals. These are obviously very small samples, but you can see the first 3 sets of bars there show the cost per admission in the 3 contractor hospitals and the 3 public hospitals. And to stress, these were local rural hospitals serving very similar sorts of populations. This cost advantage was largely due to higher staff productivity, that the staff management arrangements put in place by the contractor on the whole were more supportive and had better benefits like staff training than did the public sector. However, when you ask the question, what does it cost the government to provide itself and what does it cost the government to contract out? The cost of the contract to the government was actually more than it would have cost the government to provide those services itself. And the reason for that, well, fundamentally the reason was that the government didn't know how to write the contract to contract the private company. They actually asked the private company to draft the contract itself, with the result that there was quite a large profit margin in the contract to the favour of the contractor. Essentially, the government had not driven a very good bargain with the contractor. So what this study did was focus attention on the capacity to contract out and the relationship between the purchaser and the provider. As part of our research program, we did quite a lot of studies on contracting in different countries, including some in this region, including with colleagues in Thailand. And out of that body of work on contracting, we asked ourselves, well, what affects whether contracting out is a worthwhile policy or not? It may work in one setting in terms of leading to lower cost, better quality services, but in another setting it might not. So what are the sorts of reasons why, what are the sorts of influences on whether a contracting policy works well or not? And this sort of thinking is really important because many of the health system interventions that economists look at, they're not like a drug or a diagnostic where you put it in someone and they're likely to respond in the same way. A change in a health system, a reform in a health system, will have very different effects depending on what that health system is like, what the context is like. And so this was the diagram we produced for contracting. A sort of think piece for thinking, for any government thinking whether to contract, whether it might be a good idea or not. And so at the top in the middle, I've already referred to the issue of the government capacity to manage contracts. That governments need to be aware of their own costs, of the costs of the alternative providers. They need to have the capacity to design, manage, and monitor contracts. On the left-hand side at the bottom, the government's capacity, its own capacity for service provision matters. If it itself is unable to provide low-cost, good quality services, then that makes the contracting out option more attractive. The private sector also, what capacity does the private sector have for service provision and for managing contracts? South Africa did have a company that was effective in managing that sort of contract. That's often not the case. The private sector might not be interested at all in government contracts if the government has a reputation for paying late or not paying at all. The private sector might have more advantageous options. And then also the environment needs to have functioning legal and banking system and procedures resistant to patronage or corruption. Contracting out is notoriously an area where corruption can enter into the award processes. And I think looking at this, it's interesting that the policies of agencies like the World Bank recommending contracting did so from the premise that governments were not good providers of their own services. Governments were inefficient providers of services, and therefore they should contract out. But I think the interesting lesson of this work is that you cannot get round the problem of government capacity. And indeed, that in some ways, running services yourself is actually an easier relationship to manage than managing an arm's length relationship with a private sector provider, where you have less direct control over what goes on. And my conclusions from these analyses and the work we did was certainly that in a low-income country context with limited government capacity, that it was quite risky for the government to rely on, certainly on the private for-profit sector. The NGO sector might be a different case, but that it would be difficult to manage those arm's-length relationships with a commercial private sector. So just to move to conclude, I've given you some rather idiosyncratic examples of health economic analysis that contributes to thinking about universal health coverage. But I wanted to end by giving you a better sense of the whole scope of health economics. And I'm sure my colleague John Keynes in the audience will be familiar with this. I don't know if this diagram has gone beyond the UK. This is known as the Alan Williams plumbing diagram. Alan Williams is the founding father in the UK of modern health economics. The plumbing diagram, because it's a bit like a plumbing system in a house. It shows everything being connected up with everything else. And this diagram has really stood the test of time. It was done by Alan in the late 1980s. And still, I think, really depicts the breadth and scope of health economics in a very effective way. So I've talked mainly in this talk about box E, microeconomic evaluation, about boxes C and D, the demand and supply of healthcare, and I've talked a little bit about G, the evaluation of the whole systems level. But there are other many important aspects of health economics. Box A, the question of what influences health in the first place. Should the health sector promote intervention in other sectors like education? What is the value of health, an important precursor to thinking about economic evaluation? And then at the bottom, planning, budgeting, and monitoring mechanisms, really critical in terms of how health systems operate. Things like how should you pay your healthcare providers, for example. So all of these areas are areas that have seen a lot of effort over the last 10, 20 years in order to develop the body of work of health economics. And you can see that all of this very much provides some of the important analysis for thinking about universal health coverage. So in this talk, I've tried to show how some of the analyses that have been done have been useful for policy and have been taken up. And John Maynard Keynes, one of the leading UK economists of the 20th century, wrote that the ideas of economists, both when they're right and when they're wrong, are more powerful than is commonly understood. I think when you look at the health economics literature, cost-benefit and cost-effectiveness analysis appear to be very dominant in the body of the literature. And I think the expansion of health economics into other areas has been really important, and particularly areas like impact evaluation, what one might call the industrial organization of healthcare, and so on. I've been very fortunate in that my career has tracked the development of health economics, and that throughout my career, health economists the demand for health economists has been greater than the supply of health economists. I think those of you in the audience who are health economists will be in the same fortunate position, that the demand for your skills will exceed the supply of health economists. But I think it's also important to think that the sort of work you can do as health economists can be extremely influential, and that doing good quality economic analysis is a very powerful tool for good within health systems and in the interests of universal health coverage. Thank you very much.